So is it visible? Dr. Prashant, if you can please confirm.
Yes, Lokesh, it is visible.
Thanks. So a very good evening to all of you and a very warm welcome for today's session on ADA highlights. So at the outset, I, Lokesh Ganju, from the product management team of Mankind Pharma, welcome all the eminent panelists, moderator, and all those who have registered and who are attending this program. We welcome you all for these ADA highlights. So to begin with, sir, 1995 was the year when Mankind as a company was established. And the company was founded by our chairman, Mr. R.C. Juneja, and this company is run under leadership of highly experienced management team. And we are ranked first in terms of prescriptions. I mean, we are able to generate maximum prescriptions in the entire country, and we are ranked fourth in terms of our revenue. And our global revenue is approximately $1 billion US, and we have strong presence among prescription, OTC, and veterinary medicines. Mankind's philosophy has always been serving life, and the three pillars for this philosophy have been quality, affordability, and availability. So all of you are aware that Mankind is already well known for its quality medicines at affordable price. And with the help of our extensive field force, we have been able to provide these services at affordable price to each and every nook and corner of the country. And we have a well-established R&D center at Manesar, Gurgaon, where our major capabilities are new drug discovery and research, API development, formulation development, clinical research, and so on. And it gives me immense pleasure to announce that we have just completed, our preclinical trials on one of our new research molecule, GPR 119, and we have been granted the worldwide patent up to 2037. And we have already initiated the phase 1 studies and announced the submission of IND. So if everything goes well, by next 4 or 5 years, we'll be in a position to launch this molecule globally. So last year, pandemic had hit us, and that time, Mankind as a company, we contributed 51 crores at PM Care Fund. And as an employees of the company, we had contributed our one-day salary. And since this year, we have been able to make a contribution as a company of 100 crores to the families of all those martyred doctors, paramedic staffs, nurses, and policemen, pharmacists. So all those people who actually lost their life to this pandemic, we have just passed this 100 crore benefit to their families. So we are really thankful to all of you that with your continuous support and encouragement, we have been able to fulfill all these achievements whichever I have discussed. So we really expect the same kind of partnership in terms of caring people and all those patients out there to provide the best of the healthcare services in India. So with this, I would like to introduce one of our eminent, senior medical advisor in Mankind Pharma, Dr. Prashant. So Dr. Prashant, over to you.
Thank you, Lokesh. And I welcome again in this very interesting ADA highlight session. And again, this year, we are having various new trials, newer data publication, and that we are going to discuss here. And to discuss here, we have eminent guests and as a panelist in our session for this evening. Let me introduce one by one Dr. Amrish Mittal, sir, who is Padma Bhushan and BC Roy awardee and head of endocrinology and diabetes department at Max Healthcare, which is Pan Max group of 16 hospitals. Dr. Shashank Joshi, sir, Padma Shri awardee and chair of International Diabetes Federation Southeast Asia and Dean Indian College of Physicians and endocrinologist at Joshi Clinic and Lilavati Hospital, Mumbai. Then we have Professor Dr. Krishnaji Sheshadri, sir, Senior Consultant Endocrinology and Diabetes in Apollo Hospitals and Senior Clinical and Research Lead at Apollo Sugar. He is also Director of Primer, which is a medical education company, and PAMS, a not-for-profit medical organization. Then let me introduce you Professor Sujoy Koster, Professor of Endocrinology at IPG MER and Kolkata. And let me, this opportunity, let me introduce, congratulate him to be nominated as Clinical Endocrinology International Clinician of the Year by the American Association of Clinical Endocrinology Award 2021. He has also been awarded WIDF Award for Innovation in Diabetes in 2021. And then, not just finally, we have our own moderator, Dr. Rajiv Kovil, sir, who is Director of COVID's Diabetes Care Center in Andheri West, Mumbai, and Nanavati Super Specialty Hospital in Vile Parle West. He also been a founder member and secretary of United Diabetes Forum from Mumbai. So with this, I hand over this session to Dr. Rajiv Kovil, sir, to take the proceedings forward. Sir, over to you.
Thank you so much, Dr. Agarwal. Thank you, Lokesh Ganju, for that warm introduction. And this is another edition of Med Talks. The world has really become fast, and it has also become flat. That's the reason that within 24 hours of conclusion of the American Diabetes Association, we have top 4 endocrinologists from the country who are going to give their inputs about what happened in those 5 days at the American Diabetes Association and the Scientific Congress, which went on from 24th June to 29th of June, 11,500 registered delegate, and more than 800 presentations which occurred over the 5 days. So we are going to bring you the nutshell of it in an hour's time. So let me start off with Dr. Ambrish Mittal. Sir, for the last 7 years, we've been waiting for telling us that who will marry metformin, and we thought that the grade will give us the answer. Sir, what is your takeaway from the grade studies?
Thank you, Rajiv, and thank you, Mankind, for having me here. Good to be amongst friends again. The issue about the grade study, firstly, grade expectations, because it was the first non-pharma sponsored study.
Very true.
And it was the first comparison of drugs with each other. And as all of you know, one of the most important, most popular topics for lectures the last 15 years at least in every meeting has been after metformin what? That's been the question everyone's asking all the time. So this study was designed by like-minded people in 2008, conceptualized. And that was the time when the rosiglitazone fiasco happened and all those things were happening. So a lot of stuff was happening at that time, and people thought it's very important to figure out objectively what is the best add-on after metformin and what circumstances. So this is how it was designed, but it took a long time for them to get funding, etc. And the study could only be launched in 2013, right? And then it's a study of 5,000 diabetes patients. It's not a small study. But it took them 4 years to recruit the study, recruit patients for the study, and which I thought was a bit excessive given how common diabetes is, and there's no dearth of patients. And of course, it's a totally US-based population. So those are the things that are there in the study. We should understand the perspective that it started in 2013. So you are looking at diabetes care in 2013, and what happened between 13 and 17 cannot really be incorporated there. So what does that mean for us? It means that SGLT2 is out. And SGLT2 is out, which is probably one of the most popular groups of drugs right now. And therefore, all those were excluded, and they had no choice because, they started the recruitment in 2013. So one is that group was out. Second is that pioglitazone, thiazolidinediones were, this was when the study was conceptualized, the rosy controversy was at its peak, so that was out. So 2 groups of drugs are out of contention in this study. So what that leaves us after metformin in this open clinic trial, but the thing is that the people who analyze the samples or analyze the data were not aware of the patients, but because of the nature of the drugs, the physicians treating the patients were aware as everyone was, like an open study. However, it is still a very, very important study, and it took like 21. So you're already looking at 9 years, but the median follow-up you're looking at is 5 years. So if you're looking at 5 years follow-up, it's still good to get this kind of data. So the drawbacks, I've told you, 2 groups of drugs are out. Number 1, it's a purely US-based population. Number 3, the recruitment period is quite long. So it gets very complicated to analyze because lots of things change in that period. CGMs became more popular. So many things happened. So we can't incorporate all of it. Now, therefore, the idea still was to compare which drugs are left. It was comparison of sulfonylurea in the form of glimepiride, of sitagliptin, at that time the new kid on the block when the study was originally seen, and GLP-1 represented by liraglutide, a very, very important molecule. and the fourth was glargine. So these are fairly standard practices in worldwide. So there was nothing. So these are patients who were only on metformin. Their duration of diabetes had to be less than 10 years. And they were on 500 milligram at least, and it was up titrated to the maximum tolerated dose with a maximum upper limit of 2 grams, which is what we also do in this. So it's very clinical practice sort of oriented. And then after that, if the A1C was above 6.8, then something was added. One of the 4 drugs was added. Now, if interesting part of the study is it's not designed as who achieved the target. The outcomes are designed to see who escaped the target. So the primary outcome of the study was basically time to get an A1C above 7. So you control somebody, how soon do they reach above 7 again? And the secondary outcome was to reach A1C above 7.5. And tertiary outcome was that after achieving the secondary outcome, then when do you reach again 7.5? So you're doing like a longitudinal follow-up where you're seeing how patients are escaping from various drugs. And of course, you'll record the adverse events and the problems with individual drugs. So that will be there. So you're trying in a sense, you're really looking at efficacy of drugs in terms of lowering of A1C, whether they were able to do it in the first place or not, when added to metformin. Duration, I think one of the major things in this study is the duration and the story of sulfonylurea failure. And, we read that a lot as youngsters. Primary failure and secondary failure, whatever. No one believes in all that terminology now, but the fact is, how long do secretagogues like sulfonylurea work? And of course, did it have any impact on complications? Did it make any difference which drug was added? Because, ultimately, as we all say, we're looking at the end of the road is really the complications. That's the whole purpose of treatment. So this is how, and of course, as I said, tolerability and adverse effects. This is how we looked at the whole thing. And it's a very interesting study in that sense. There's 5,000 people, and I've already explained the 4 arms. Now, the thing is that the data has been unlocked very recently. So one of the challenges, again, a challenge with GRADE was the fact that you got the data, you could have missed some of the cardiovascular. They were not properly adjudicated. And in CV events, even a few here and there could upset the cart. So they were not properly educated, and at least 10% were still left. And there was little confusion, which could have perhaps been avoided. But anyway, I'm sure the investigators did their best. Also, of course, there is a concern about the fact that some of the data they go on saying it's preliminary, and so they're kind of little defensive because they haven't done it yet. So I guess the excitement to release it at ADA was too strong and overrode some of the very finer, nuanced solidities. Anyway, so this is how it went, and I won't sort of labor all the inclusion/exclusion criteria. I don't think that's required. But the thing is that the other really remarkable positive part of the study was retention over the course of study was remarkable, above 90%, 93 point something, 93.7% actually. And the loss to follow-up was only 78 out of more than 5,000, which is actually very, very impressive. Adherence to study visits was high, and I think that was a lot to do with free medication that these people were getting. The company supplied the medication free. And even the A1C data is like close to 100%, 98%, 97.3%. So those are great. That is great stuff. Now, the thing is that it's a study that actually makes you sad in a way, because it also tells you how poorly we are doing even in a clinical trial setting with management of diabetes. So 71% of people develop the primary metabolic outcome. Remember that metabolic outcome is escape of A1C beyond 7. So 71%. And there were non-compliances. There were more with some and less with some. We won't go to non-study glucose lowering medications. But the thing is, the single line message from the primary outcome is the fact that it took the longest to escape from liraglutide and the shortest to escape from sitagliptin. So you're really looking at sitagliptin patients escaping early. In fact, according to this study, people with an A1C more than 7.3 sitagliptin is more or less not effective, actually, which is contrary to our clinical experience. It's hard to believe that having used sitagliptin added to metformin in like thousands and thousands of patients, it's hard to say it doesn't work at A1Cs above 7.3 or 7.4. It depends on many other factors. But nevertheless, that's what the finding. But in general, the trend was correct that gliptins work only at relatively lower A1Cs. You can't expect them to lower a 9 to a 7 or something, right? So one was sitagliptin was the weakest of the agents, which is also what our clinical experience tells us. And liraglutide was fairly powerful, and it stayed longer. And I'll have to read the day differences, but the mean time to reach with liraglutide was 185 days longer than that with sita. 72 days longer than for glimepiride, and 21 days longer than for glargine. So actually, even longer than glargine. So liraglutide in the first instance, as an add-on to metformin, worked really well. But what about secondary outcomes? And we won't again bore you with all details. The fact is that even in secondary outcomes, sita and glimepiride fared poorly as compared to glargine and liraglutide. And in the secondary outcome stage, I suppose when the diabetes is a little more, has been there for a little longer duration, glargine scored over liraglutide in this. But those two were there, up there, and the sita and glimepiride were lower, which means that, again, what I mean is that there was longer time to escape from lira and glargine as compared to these OADs, which are primarily secretagogues. So I think this is how I would look at the study. One or two lines about the CVD data, which is still extra data. It's not solid data.
True.
Nevertheless, it did suggest that when you put together all kinds of things and cardiac outcomes, then liraglutide did better. Not in 3-point MACE alone, but you had to add everything. Hospitalization for heart failure, civil angina, all revascularization procedures. When you put it all together, then yes, then it seemed that that liraglutide did offer some cardiac protection. But we know from leader study that liraglutide is an agent that does help in cardiac protection. But we don't have solid data from this. So therefore, basic conclusions of the study are that this when you add drugs after metformin, then you have to use your normal individualized basis of therapy. Some drug is appropriate for some patients, some are not, and it sort of confirms what you think, that secretagogues don't work endlessly, and people tend to escape earlier. And of course, it confirms that insulin will always work, no question about that. And also, when there is some insulin reserve, probably liraglutide works really well, and possibly maybe the only agent among these, which also you expect actually to have favorable cardiovascular outcomes.
True.
So the last point here would be, of course, the body weight. You know that again, the body weight followed predictable pattern. It's too boring to discuss, but you know that liraglutide did cause some weight loss. And the other, there's not much weight gain though. That's important. There wasn't much weight gain in the glargine group or the glimepiride, so that's important. Hypoglycemias were maximal in the glimepiride group, but overall hypoglycemia, I'm quite amazed how low it is. Overall hypoglycemia is quite low. It's severe hypoglycemia. It is quite low.
Glimepiride more hypoglycemia than glargine also.
Yes, it had, which is also not contrary to clinical experience.
Absolutely.
So one does find that, and of course the GI side effects, etc. But I think these are important points to be made from the study. It's a very educated study, gives us a lot of ideas. One key point that probably will appear in sub-studies or later studies would be, who are these people? Who are the ones who escaped initially? What are the phenotypic characteristics? Have they done any kind of genotypic studies on them, or are they planning anything? Or at least phenotypically, will it help us choose these are the people who are not going to respond to the secretagogues or to sitagliptin at all? Do we have any defined characteristics? It's early days. I hope that they have captured all that, and I'm sure that at some point when detailed analysis is done, this will appear.
Thank you so much, Dr. Mittal. Dr. Joshi, thank you so much. Dr. Joshi, Dr. Krishna, Dr. Ghosh, any additions to what Dr. Mittal said about the GRADE study? does it add value to us?
Very quickly, 2-3 points. I think Amrish has summarized this whole study. Number one, very US-centric study led by David Nathan under US regulations. So not applicable for India, number one. Number two, their poor response to gliptin is because they don't eat carbs in their diet. And we have a better response. That is a very well-known fact that Indians and Koreans do better than others. Number three, injectables score over orals. That's a very straightforward message which comes out. And in the injectables, obviously the weight loss advantage of liraglutide scores over glargine. But glargine surprisingly did very well on the hypoglycemia front. I mean, the severe hypoglycemia of glargine is actually even better than glimepiride. And the last thing is that I would definitely love to see the detailed results in public domain. David Nathan is one of the finest diabetes investigators for the last 3 or 4 decades, a very high impact factor. So, but I think he was very, what you call, conducive in the way he disclosed data yesterday. So I would definitely like to see a little more sub data analysis, subset analysis. And I think he was very miserly yesterday on a lot of data points. And I'm sorry, I mean, Amrish, but that's what I felt. I think he's so transparent. But yesterday I thought that he was semi-transparent.
He was defensive. He wasn't sure of something. Didn't want to say anything.
That's correct. That's correct. Which is very, very unusual for David to see. And so was Julio Rosenstock and the others. So I think some of them are some of the lead clinicians of the world, and I think we look up to them. But I think they presented the study a little bit in a haste, a little bit delayed, and I think they will still need another 3 months to really put their act together. That's what my feeling is. Maybe Sujoy had something to say, and Krishna.
One point I'll make here is that clearly some of these authors, these eminent authors, actually were the ones who wrote editorials on gliptins being useless. Like I remember that, reading that the gliptin group of drugs is completely useless. So you know, that's okay. That's an opinion, and that was in early days.
So in the US, no, they don't count gliptins too high. They feel it's a very weak drug.
Yes,
like our part of the world.
So as weak as they think.
That's how they think. So that's up to them. But I think we know the value of gliptins. But maybe Sujoy was raising his hand, so maybe he had something else to say.
Right. I think this study reminds me of UKPDS. MRC funded, NIH funded. And like UKPDS, we'll have probably 30, 40 papers out of the data that's there. That's number one. That's probably the reason why in a presentation, people can't actually, talk about a lot of data. Because there are so many things to come on and look at in the data. And just a couple of things that I thought of adding. Number one was, I was a little bit surprised about the initial primary sitagliptin failure. Something that we probably do not, identify with. But that's one way of looking at it. The other good way of looking at it as a poor Indian is that glimepiride is a good drug. All this talk about beta cell dysfunction, beta cell exhaustion, beta cell failure, at least glimepiride has proven that, it's probably as good as sitagliptin in terms of beta cell reserves, probably better. And the only reason it might be better to my knowledge is, see, for the sitagliptin, all that you could do is give a 100 milligram tablet. Whereas for the glimepiride, you had the option of going up to 8 milligrams in divided doses. So that would probably be one way of saying that, you probably had to up-titrate the glimepiride dose, which is not discussed at least in the slides. That's number one. The second point is, like Professor Mittal said, that they've not talked about the outcomes and 10% of the CV events are not adjudicated. In one of the slides, it's mentioned that the MACE events, it's not powered enough to make that comment. So I am not very sure whether we will be able to at all make any comments about cardiovascular safety. But at least on the overall, if you look at glimepiride, because that's the one that we keep on blaming about cardiovascular bad events, that did not have bad events or bad signals up to the point that we saw in the data that got presented. So that's one way of looking at it. And the third thing, because every time we talk about sulfonylureas, we talk about beta cell dysfunction or exhaustion, we talk about hypoglycemia, we talk about weight gain, and we talk about cardiovascular bad effects. None of those four got substantiated in the GRADE study. As an Indian, I'm happy for that. I would have actually and the Europeans are not happy because glyclazide is the sulfonylurea prescribed in Europe. And that's probably the reason why they were critical about why is glimepiride being used and not glyclazide used, because there might be differences between the two molecules. So that would be my defense for glimepiride.
So that 10% which is still unlocked from March till now, till June, may give us more answers probably. Dr. Krishna, your take on it, please.
So the first thing that strikes me is, isn't the study is about 5 years too late. I think the world has moved on from that kind of practice. I think that's the one. We do far more combinations. We know a lot more, and irrespective, we've heard so much in the last 10 years. This is the first part. The second thing is, if you look at the curves, that you look at the inexorable march of beta cell dysfunction. That irrespective of a slight difference between each of these, none of these are able to arrest beta cell dysfunction. That includes the GLP-1 receptor analogs, which is interesting because you get to see 5.8 and those kind of A1Cs with Lira, but they're not able to arrest the march of beta cell dysfunction. I'm just cherry picking because everyone's covered all the other points. The third point that is that irrespective of the amount of height that grade has gotten, if you look at it, it still represents about 9% of the US population. If you match with the US diabetes population, it will probably apply to about 9 to 10% of the population. Fourth, again, is to remember, is to remember that that the number of patients with a baseline cardiovascular risk is not very high. So that way, it sort of gives you a reality check that that we have been so obsessed with the CV outcomes that you don't see that that big numbers. And I was very surprised at John Buse's presentation, very somewhat unlike John Buse, because he had to say so many times that that it was not powered, and he actually brushed aside the heart failure data. So let's wait for the publications. This will be a slow release publication, but I have a feeling that that grade may not ultimately make a great impact on our practices.
Thank you so much, Dr. Krishna. So
a couple of points before we move ahead.
Yeah, please go ahead.
One is, I think it's important for people to understand it's not a CVOT, as rightly pointed out by Sujoy and Krishna both. And I think that's important. The study is not powered. There won't be enough events anyway to figure out, because the CV risk is quite low. So probably and why do we need a CVOT? We don't need a CVOT. For all these molecules, we have CVOTs. I mean, we have glargine, we have a large CVOT. For all of them, we have CVOT. So I think we are not concerned about that. It generally conforms to the kind of clinical sort of setting that one sees, the clinical picture that one sees, with the caveat which everyone's pointed out, that gliptins are not that weak as they're made out to be in the American population. Otherwise, it generally fits in with what we see. And the most important point of the study, which I think Krishna brought out actually, is that type 2 diabetes is a progressive disease. And whatever you do, ultimately there is increase in requirement every few years. As Sujoy was comparing with UKPDS, I mean, that's what the UKPDS showed. But in this study also, you're seeing people just keep on escaping, regardless of what therapy they're on. Some earlier, some later, but you can't keep patients on very long on any therapy, and it's a dynamic process. I think that's the important message for our colleagues.
Rajiv, I know we're running short, but
one
point.
point.
We've been, so on the one hand, you have these clinical trials and what they bring in. On the other hand, we have these data about clusters and others. And you see there's a mismatch that's happening here. You're not able to see any specific, at least we haven't seen so far, any specific subgroups that emerge, at least in the US population, where one is better than the other.
That's right. Very important part of this. I mean, that should come out, I hope. That's really important.
And on the other hand, we talk about clusters and the relationship between therapies. So somewhere there needs to be, a transition or at least, a meeting of these very separate kinds of data that's happening right now.
Exactly. Thank you so much, Dr. Krishna. I like the fact that you are on a swing and speaking to us like all of us are on a straight back up chair and doing this, So the next question is also to you. Do you think the twin cretins are going to change everything with their euglycemic potential and weight loss? Are we going to have everybody going into remission, and is it the next big thing? And what about the SURPASS studies also? What's your take on them?
I think from that point of view, I think this ADA has been an endocrinologist's dream. We have been talking about weight loss with metabolic therapies, and the difference between what metabolic surgery can achieve and what metabolic medicine can achieve have been completely different. We've been scratching up to 4-5%, while metabolic surgery brings you 15%. So by design, if you look at how pharmaceutical industries have worked, is they have kept the ultimate objective is to equal metabolic surgery. And you notice the first stretch of studies that came out were all the dose studies. You will see STEP, you will see the Award 11 study that started looking at higher doses of semaglutide and higher doses of Dula, showing greater amounts of A1C reduction and greater amounts of weight reduction. And then, of course, now tirzepatide has come in with this amazing. I'm going to use SURPASS-2 as a thing. I think all the others are important also, but I think SURPASS-2 is something that we should look at because it uses a GIP GLP-1 co-agonist that works together in about 3 doses, 5, 10, and 15 milligrams every week, as compared to 1 milligram of semaglutide. Remember that there is an issue here because since the start of the study was with 1 milligram semaglutide, we have a 2.5 milligram dose of semaglutide. So really, we should be comparing the two. But even otherwise, this brings in some amazing piece of information because head to head, here is an existing GLP-1 RA, and these were about 1,880 patients who were randomized to either 3 doses of tirzepatide or 1 dose of 1 milligram of semaglutide. And the interesting thing is, one is the adverse events, but not much to sort of compare between the two. The average weight in this population was around a BMI of 33 or 34. But again, what we are seeing is with the semaglutide, you saw the A1C around 40 weeks to around 6.4, but at the 15 milligram dose of tirzepatide, the A1C dropped to 5.8. And I remember in the initial studies when John Buse was presenting liraglutide, we were asking him, are these remission data that we are seeing? But I don't think so, because as I said that, once you stop these probably go back. But this is very interesting to see normal A1Cs. And in the SURPASS one where they were compared it with glargine, with degludec, and that's a good risk that they took. When compared to degludec, you will find that they were not able to get the A1C down below 6.5 in a majority of patients with degludec, but you will see amazingly a lot of people get down to an A1C less than even 5.7. For example, in the let me just do with SURPASS-2, you will notice that about 90% in the 15 milligram dose and about 85% in the 5 milligram dose get to an A1C of 7. Remember, semaglutide does the same thing, 80% less than 7. But when you think about normal A1Cs, an A1C less than 5.7, 51% achieve an A1C of less than 5.7. That's really amazing piece of information because the GLP-1 RA GIP combination does that. Even more interesting is the weight. The average weight, as I said, was 93. And in the 15 milligram dose, you get to a weight of around 81.6. That's numbers that you generally don't associate with, at least in Western studies, with GLP-1 RAs. And that's really what you're seeing. And about 40% of patients achieve a weight loss of 15%. That's really impressive. About 9% of patients on 1 milligram of semaglutide do that, but 40% do that with the 15 milligrams of tirzepatide. Not much to speak about in terms of adverse events. So one thing about the tirzepatide study is that you must remember that they did a lot of slow titration. So by the time these people achieved, the full dose, the 15 milligrams, it was almost, half the study. So the rest of the stuff is what you see, but the nausea is not much to write about, not in any other this thing. But what you're seeing is that you will see in the next 10 years a serious challenge to metabolic surgery. And also you remember that there is also combinations of centrally acting agents that are working through through the ARAS, along with hypothalamic active agents that are all coming in. And I'm sure everyone's going to also throw in the SGLT2 inhibitor on top of this. But this space, the GLP-1 receptor agonist plus GIP-1, and wait for the tricretins and the quadricretins that will sort of show up in the next.
You never know.
For cretins like us, this is very interesting. But these cretins are going to really shake up obesity and probably metabolic medicine as we see it. And if I were seeing where we go, if I was somebody who wants to subspecialize in a branch of surgery, I would not join afresh a metabolic surgical course at this point. With that, I'll stop and I'll hand over to everyone else.
So to Sujoy, Dr. Joshi, and Dr. Mittal, do you think that with this twin cretins, I don't know whether the name has been coined right or not, but do you think that an HbA1c of 5.7 as their phase 2b and SURPASS data shows that there are 40% people, 50% people achieving 5.7 and below, would that be a realistic target in future? Would we have that kind of target set in?
If I could respond to that, I still remember a debate that I did as a DM trainee. At that point of time, Advance and Accord had been published, and people were saying it might be dangerous to lower HbA1cs below certain values because it showed that people were dying. And I was supposed to speak about saying that we should probably go on lowering A1cs. So actually at the end of the debate, I asked people to raise their hands if they were non-diabetic. And a lot of people raised their hands saying that they didn't have diabetes. And I said, you guys better push your A1cs up, otherwise you're going to die, because that's the kind of logic people are trying to put forward, that if you lower things too low, things might be bad. So essentially, I think when we were talking yesterday also about the type 1 diabetes draft guideline, I think one of the points that I was trying to make is that we could lower A1cs to as near normal possible, provided we are being able to do it safely. So I'm sure in future you will have studies to show that 5.7 is better than 6.5, provided you're able to actually lower that 6.5 to 5.7 safely, that is without hypoglycemia, without worsening cardiovascular risk, and without having other problems and side effects, tolerability, because that's again a major issue. And the good bit about SURPASS is, particularly if you look at this semaglutide, that's the SURPASS 2 study, the side effect and the tolerance of 5, 10, and 15 milligrams is the same as semaglutide 1 milligram. So we know that GLP-1s have problems with tolerance issues, at least in certain individuals. But the fact that you are getting such huge amount of A1C reduction, almost to the tune of 2% A1C reductions, at no extra side effect compared to other standard GLP-1s, is something which I think is really, really promising.
Dr. Joshi?
A couple of things. These twin cretins appear attractive, but I would be cautiously optimistic on 2 counts. They appear to be too good to be true, but I think we need a longer pharmacovigilance on them long term. That's number 1. Number 2, the semaglutide story just unveiling, and here you have something tipping them to the post. So, and to scaringly low normoglycemic levels at 5.8 and below. So I think that's a little overzealously enthusiastic. These are welcome drugs, as Krishna said, that these are, the new cretins, and, they will keep on adding to our armamentarium. But I would be cautiously optimistic for another couple of years till they become standard of care. I don't see any of these molecules in India for the next 2 years at least. Sure. We will now just start getting semaglutide. So and I feel that these molecules, I think the impact and the action looks very attractive. My only challenge with them is the long-term safety and durability, and if they don't throw out any unusual side effects. Because normally when we have such potent molecules, after a couple of months or years, some unusual side effect may occur. So if that they pass through the pharmacovigilance, it's a dream pill or a dream drug for medications for diabetes. It will be virtually like a reversal drug. So it's actually competing, in that space. So that's scary, to be very frank. But at least we have some early results, and let's hope and wish that they are able to persist with these type of data when the phase 3 and the launch evolves, and let's see how it shapes up in clinical practice. But as I said, I'm cautiously optimistic, and I'm a little, with a little tinge of skepticism there. Thanks.
Dr. Mittal, any addition to what Dr. Joshi has said? You have to unmute yourself, sir.
Muted, Amrish.
We had this urgent call from the ward. So I think on the face of it, it looks very exciting. There is no doubt about it, because the kind of changes you're seeing here, you haven't ever seen. And conceptually, it's very interesting also that the GLP-1, facilitates action of a GIP, facilitates action of GLP-1. And so it's conceptually very interesting and an exciting area. The results actually initially just look too good to be true, but you read carefully and it's actually like that. So I would, of course, I think there will be much more issues of tolerance than this says. I hope there won't, but what we've seen with GLP-1 and our Indian patients all having upper GI issues anyway, I think that will be one big challenge, bigger challenge than what you think. And we'll realize that when we start using semaglutide, maybe later this year or next year, that GI issues are actually quite a big challenge in our population. And of course, when something looks too good, then one has to always wait for unforeseen side effects. As Shashank said, you cannot be comfortable till it's sort of been there for some time and had enough follow-up and enough this thing. So very exciting, nevertheless. There's no question about it. So I think it's a remarkable concept, a very bold study, not one study but a whole bunch of studies done very systematically, and I guess it's a major advance in our approach to type 2 diabetes.
Thank you so much, sir. Next question. Okay, yeah, Dr. Krishna, go ahead. You have to unmute again.
Just one point, Rajiv, and I go. Actually, one of the interesting things from people who watch trials is the nature of the design of the trial in the SURPASS is superiority. They're not looking at non-inferiority but superiority, which I think is the right one. No more of placebo. I think I think these are two things that I really like about these trials. One, not looking at placebo but actually going bold and doing non-placebo based trials. The second thing is, superiority is a primary outcome and not non-inferiority primary outcome. I think, from a clinical trial perspective, I think that is the way to go in terms of big molecules.
Completely agree with you, Dr. Krishna. Head on with
Saxa had a superiority design. Saxa didn't succeed.
Yeah, but here head on versus degludec and a CVOT head on versus dulaglutide. So looks like a promising. So from bold design of SURPASS to a very bold person in India, Dr. Shashank Joshi, do you think DARE 19 is a very bold trial? And yesterday at an post-ADA update, one of the questions asked was a very simple and a naive question, that is DARE 19 a positive, negative or a non-inferior trial? What is it?
So DARE was a very daring trial, I must say, in COVID times. And I think, DARE 19 results were basically, it is actually the first large randomized RCT of SGLT2 to address benefits and risk in hospitalized COVID patients. And what they gave us at ADA was an initial glimpse of a subgroup analysis who were at risk. And Mikhail Kosiborod, who presented that analysis, on Sunday, was very clear that they were presenting the data at the ADA because they had over half of the patients in the trial had type 2 diabetes at baseline. So remember, one of the things that DARE 19's trial had is 50% of the people already had diabetes at baseline. So that's something which we need to recognize and be mindful of. And we all know the impact of SGLT2 inhibitors on, end organ protection, heart failure, chronic kidney disease. And therefore, this trial was generated with the hypothesis that in a COVID setting, would there be some impact? And that's something which is there. This was designed actually in March and April of last year. And they had to recruit almost 1,250 patients. They were looking at, people with high-risk cardiovascular disease. And they were able to enroll their first patients last year in April 2022, 2020. And they had, almost 95 centers, 7 countries. And they were able to get the last randomization done in Jan 1st of 2021. So obviously, what is unique about DARE is that the daring to do this under a COVID environment. So I think that is definitely credit worthy. And what the trial provides does not really provide great answers. It doesn't meet the endpoint. One thing is very clear, that their primary first endpoint was the first occurrence for new onset of respiratory, cardiovascular, kidney organ function during the 30-day treatment period, or death and follow-up. And then they had secondary outcomes. So fundamentally, what DARE 19 has done in the early results, again, I would say these are early results, is looking at some early data on potential benefits of risks and of using SGLT2 inhibitors to treat hospitalized patients with COVID-19. So the trial did not meet the statistical significance for the primary endpoints. The details of the efficacy results are very interesting. And definitely what the principal investigator, Mikhail, said is that they warrant better science in the future. The safety results are of immediate clinical relevance, given that prior recommendations were to stop these medications, even if there were established indications for this class. So potentially what it says is that maybe, I would say again the word maybe, it's okay to have an SGLT2 on board, but whether it is protective, whether it has any anti-COVID impact, we don't know. So I think that's where I would summarize DARE 19. I'm certain Sujoy, Amrish, and Krishna will have their own viewpoints. But I think definitely to do an RCT in COVID space, that too on a drug like an SGLT2 inhibitor, definitely is very daring. And that too, they are able to successfully recruit, more than 1,200 patients, I think is pretty unique. So what it does, I would say, is reassures us that if there are people living with diabetes who get COVID with the SGLT2 on board, our knee-jerk reaction to suddenly abruptly stop may not be, always the wisest things to do. And there may be a little skew on that recommendation. So this has happened all the time. COVID being predictably unpredictable, whatever we start, after a couple of weeks, evidence evolves to the contrary. This we have consistently seen in the last 2 years. And DARE only solidifies that. But it definitely doesn't say that it's really has any impact on COVID per se. And as I said, that the big drawback of DARE 2 is that 50% of people were with diabetes. So that's something which you have to be mindful of.
Dr. Sujoy, Dr. Krishna, Dr. Mittal.
So if I might add, I was fortunate to be part of the DARE 19 study. Dr. V.K. Chopra was the national head for this particular study. And like Dr. Shashank said, I had a difficult time to do this daring study and convince ethical committee to get permission for the study. And I think we've got to look at it at the perspective of when we did the study. The primary goal was to establish safety of SGLT2 inhibitors. I'm not very sure people were that confident that it will actually reduce the risk of outcomes. Why I'm saying that is, see, like any CV outcome trial or otherwise that we talk about, you tend to choose the highest risk people in that particular group to show that there are benefits. Now, if you look at the study design of DARE actually looks at moderate COVID. It does not look at severe COVID, because the starting point is people who were either off oxygen or needed at the most 5 liters of oxygen. That was your kind of starting point for DARE 19 study. You were not starting off with people who were already ventilated or people who were going down that line or very likely to go down that line. So if the question that Rajiv you asked, is it a positive study, is it a negative study or a neutral study? I would say in terms of the safety profile, I would say it's a positive study or perhaps it's a neutral study. Why am I making 2 comments there? In the hands of people who are aware of what might go wrong, if you use an SGLT2 inhibitor, you will not land up into problems. But we don't know if you start using it left, right, and center, whether things will go wrong or not. So, that's the bit of caution that I would throw in there. In terms of the, benefit of an use of an SGLT2 inhibitor, I would say it's at this point of time, it's a neutral study. But had you chosen people who were more likely to have adverse outcomes and tested the hypothesis of treating people with the drug versus placebo, you might have had benefits. So that's my balance of the efficacy and the side effect of their 90.
Fantastically, very well put, Sujoy. Dr. Krishna, Dr. Mittal? Yeah, Dr. Krishna, go ahead.
So my point is, maybe to add a disclaimer, is done by professionals, don't try it at home. So what we need to be careful about, and everyone's talking about is that at this point of time, the guidelines don't even talk about starting SGLT2 inhibitors inside the hospital after myocardial infarction. Right? They don't say that, do as soon as an MI occurs, you start it. They advise caution and say start it afterwards and a little delayed and stuff. Even though there is data accumulating to the contrary. At this point of time, I'm not so sure that with this information we should change the way we practice of stopping SGLT2 inhibitors when patients come into hospitals, let alone starting SGLT2 inhibitors in someone who's got severe COVID. So I think I leave it with the disclaimer I said, because I'm still think that this is a study that has been done by really amazingly good professionals in a very controlled environment where they have a good idea of what they're doing. Not for us who walk in, make a consult, and then have somebody else take care of the patient and walk out. Right? That's my view.
If I could add just one point, I think at least it gives us now the confidence to convince ethical committees to do more studies in the acute care setup. Whatever we are looking at, whether we are looking at people with other acute problems, where the very question that you raised, that the convention has been that we should not start or we should stop people on SGLT2 inhibitors for other acute situations as well, which is very true, which is very right, at least with the evidence that we have at this point of time. But at least we will probably have the guts to do it.
In fact, that was going to be my first observation, that I would love to meet these members of the ethics committees who actually approved this. I think Ambrish had a point.
Yes, sir. So you have to unmute. You have to unmute yourself.
I was just saying, Dr. Chopra is my colleague, and we were the lead center for this trial. And I really fought with him. I said, "You're completely crazy that you're agreeing to do this and be the national lead for this trial, which is, how can you do that to COVID patients, literally?" But it seems that all ethics committees agreed across the country and across the world. And actually, I think that may also have been led by the fact that there was a lack of efficacious drugs for COVID, may have allowed people to experiment a little bit more in the COVID setting. After all, we're experimenting with so many things in COVID, why not this too? So I guess that was the thing, and I'm not very excited by the study. It's neither here nor there, but it's okay. That's what was expected. It's all it tells you, at least for one, is that you don't always have to discontinue these drugs in patients who are hospitalized, for at least with COVID, and probably with other things. It's not mandatory. We weren't doing it anyway for everybody, but it's not mandatory. Even in sick patients, it's not mandatory. You have to see what the patient's profile is, whether there are fluid electrolyte issues and whatever. That's different. But otherwise, you don't have to discontinue everybody. I think I'll just leave it at that. I don't take more than that from the study.
Thank you, sir. Last 10 minutes. So I'm going to ask 2 questions to Sujoy, rapid fire, and then we'll have the rest of the panel answer. Sujoy, your take on amplitude, on FP glenatide, and also the management of type 1 diabetes, the document, and especially the investigation in a suspected type 1. What's your take on it? You have to unmute, Sujoy.
The first one is about the amplitude study that you're talking about. Well, this is different from all of the previous GLP-1 studies in many ways. Here you have a CV outcome trial with a GLP-1, which is an exendin-4 based drug. Remember, all of the previous exendin-4 based GLP-1s failed in terms of superiority of cardiovascular outcome trial. Here is one where it succeeded. And additionally, this is also a renal outcome trial, which was powered enough to make comments about the renal outcome. And it's a placebo-controlled study. Now, the challenge is in all CV outcome trials, we kind of want a glycemic equipoise, which did not seem to happen in this particular trial. The difference between the A1Cs between the 2 groups was as high as 1.24. So whatever we conclude I think we have to keep in mind that the difference was 1 in 4. Itself might be enough for improvement in my in UKPDS, like for advanced, like for in accord. So I'm not very 100% sure whether the benefits is because of the in terms of the microvascular complications. But anyway, if we take it that this is like a CV outcome trial and a renal outcome trial, at the end it did show that if you look at all different endpoints of the MACE, that there was improvement in the 3-point MACE, there was improvement in the composite renal outcomes, the safety and tolerability, which is always an issue for GLP-1, was reasonable, and the other issues like say pancreatitis and stuff like that we blame the GLP-1s has not happened. One of the other concerns was that here is a molecule which is bound to IgG4. We know there is a lot of IgG4 diseases, including the thyroid, the pancreatitis, the hypophysitis, autoimmune pituitary disorders. That at least did not seem to happen in this particular study that we are talking about. So that would be in very, very brief, and you had very good A1C reduction. And finally, here is one GLP-1 outcome study, CV outcome study, where you had a substantial number of people who were on SGLT2 inhibitors.
Sure.
And there has been a comparison of what happened to those people who were on SGLT2 inhibitors and the GLP-1 versus those who were not on the SGLT2 inhibitors and the GLP-1. Because a lot of times, even if you look at international guidelines, it's as if it's an SGLT2 inhibitor or a GLP-1. Here you can at least even look at and combine and say, are the benefits happening over and above the SGLT2s? That there did not seem to be any difference between the ones who were on SGLT2 versus the ones who were not on SGLT2s. The numbers were not great. It was about 15 to 20% of the population were on SGLT2 inhibitors. But that's something that you and I would actually want to look at, because that would probably say even the renal benefits were because of SGLT2. So that bit of the analysis at least suggests that this is a pretty good drug in terms of what I've discussed. So that's more or less, if you ask me, about the amplitude study, and which, if you look at the numbers needed to treat kind of the renal composite, you needed to treat about 19 individuals over almost 1.8 years. And for the others, it was all between, say, around 40 to 45 that you needed to prevent one event. That's in very short the amplitude study, if I have to talk about. And you've talked about the type 1 guideline, which itself is 93 pages. But, we are talking just about the diagnosis bit. Conventionally, our teachers have taught us that first look at the history of the patient who comes to you to figure out whether this is type 1. And, the things like ketoacidosis is not necessarily a feature of type 1 in adults, because you have a lot of ketosis-prone type 2s as well. So don't bank on that. The second thing is the rapidity of onset. I think because the guideline, to some extent, to me, my understanding is more like a LADA plus type 1 guideline rather than a pure type 1 guideline, because it talks about that don't look at C-peptide in the first 3 years of the diagnosis of the diabetes. Perhaps, and the algorithm of the diagnosis starts off by measuring GAD65. And the other thing that we've been told is that do not look at ICA, the islet cell antibody, because there might be problems with the assays that you do. So look at the GAD. If it's not positive, then look at the IA2 and the ZNT8. And then if you are worried, once you've got the antibodies positive, it's almost taken as if all of them are type 1s. But I think in India, a lot of us see LADA. So it might be a good idea to actually look at C-peptide first and then the LADA, then the antibodies. The other thing that they've talked about, which they have not referenced in the guideline that they've talked about, and I don't know where they've got it from, is they've said that you don't need to do any special test for stimulated C-peptides. It says do a random C-peptide as long as the last meal has been within 5 hours of the test. So you can take whatever meal you take, and within 5 hours of that, you take a random C-peptide. If values are less than 200 picomoles, it says that it's suggestive of insulinopenia. Anything above 600 means that it rules out insulinopenia. Anything in between, wait, reassess. But that's what's been kind of talked about. But and this document is up for consultation, and you can put in your comments and revise the comments if you want, the document.
Rajiv, you are muted.
Rajiv, unmute.
Unmute.
Sorry. That's it. Dr. Joshi, Dr. Krishna, Dr. Mittal, would you like to add something?
I agree with Sujoy that Amplitude O is a very compelling trial. And I think I congratulate them because it's published in New England Journal of Medicine. It clearly shows that an exendin-based GLP-1 receptor agent, and there's a lot of heterogeneity when it comes to cardiorenal outcomes. This is one trial which clearly shows that an exendin-based GLP-1 receptor agonist like epaglinide, can clearly be effective as a cardiorenal drug, because this has effectively and safely reduced cardiovascular as well as progression of kidney disease in people with long-standing diabetes who have high prevalence of cardiovascular and renal disease. So that's very, very compelling. And also, the effects were similar in presence and absence of SGLT2s. So again, that is also very, very compelling. So if you ask me from a standpoint of, transparency of data, publications, they have done a fantastic job. A little too late in the day, in this whole class, but I think I'm very impressed. As far as the type 1 diabetes guidelines are concerned, I agree with Sujoy, they are under review more and more. You see, type 1 diabetes in the reimbursed world like US is very different from type 1 diabetes which we treat in India, because in India we have a lot of resource limitations. So, in India, type 1 diabetes have people with premixes to basal boluses, to carb counting, to pumps, and to CGM access not being universal. While in the US, more than 1/3 of that population is already on a pump, and almost every type 1 diabetic has a CGM. So obviously the tunnel and the window of their guidance is going to be very different from what we will see it in our population. That's all I would like to say.
Dr. Mittal?
Nothing except that this study, which seems very impressive actually, and even the results, and the main thing is that it's not a GLP-1 based, it's more of an exendin based molecule, and it's actually showing positive results in whatever manner of CVOT you call it, but it is positive. And I mean, all the things are good about it, but I understand the molecule development has been stopped, if I'm not wrong.
Correct.
Yes, sir. It's like an orphan. Somebody held its hand for some time and gave it up.
I think Sanofi is having some bad luck with molecules. But anyway, the thing is that this, I don't know why they abandoned, probably because Dula and others were well ahead in terms of their studies. But in terms of clean data, this actually looks quite good to me. I don't see anything negative, really strikingly negative. No, it's good that they dropped it. No, I think it should have been there. It would have given the others a run for their money, but we don't know so much about semaglutide in clinical usage yet, so I can't compare with that. Maybe that would outgun this, but nevertheless, as far as the trial goes, I think it's a good trial, and despite the drug development being abandoned, it's, as Shashank said, it's in the NEJM, and it shows good things about GLP-1. At some level, it reinforces our faith in this class of molecules. I think at least that much is very much there. That's all I have to say.
Thank you, sir. Dr. Krishna, your final take on it?
Things. One is two interesting points. One is, if you look at the subgroup analysis, you will see two things. One is women doing better than men in the subgroup analysis. That was an interesting point, because this is a question that we've always wondered, whether there are sex-based differences in GLP-1 receptor analogs. You won't see it in the other trials, but this one has one. The second, of course, is what you see, that the greater the beta cell dysfunction, the better the GLP-1 receptor analogs do, elderly doing better in terms of outcomes. This is the second bit of the whole story. The important caveat is that the renal composite had only one major renal parameter, and once you went down to that, it did not show significance. So I think I would interpret the renal composite very carefully. The type 1 diabetes, just one comment, it's true that it is very interesting, because the principal, the authors of the story of the article have some of the longest experiences and largest experiences in the clinical practice of type 1 diabetes. So it's very, very, very interesting for us to look at it. This is one. The second thing is, for the first, mainstreaming of psychosocial constructs, evaluation of psychosocial effects, and taking help from mental health care professionals as being part of an algorithm is something that is very, very interesting in this. We should wait for the final publication and comments, but I think, this is something that struck me because a lot of patients with type 1 indeed struggle through transitions. And our trouble is, and our big issues are not insulin, but actually getting people to take them correctly and taking things right. Both papers are really, really interesting. If you have the patience to read the second one, and if you have the time to read the first one, it is worth going for.
Fantastic, sir. Any comment from any of y'all?
Well, I'm looking forward to going to the ADA next year in person. I think that's really the one comment I have.
You bet, sir.
New Orleans. So I agree with Krishna that we can all be in New Orleans, and I think that's something which we are all looking forward to.
4 intelligent people come together is actually a poetry in motion. Fantastic. To within 24 hours in your busy academics, busy practice, to go through all this data and come up with it, and such wonderful discussion over the last 1 hour. I believe whoever has logged in has got a nutshell of the ADA. Those 5 days, he didn't have to go there from a Thursday to a Tuesday. He saved on a lot of energy and everything, and he got everything that he wanted to, except the fries and the beer. Thank you so much. Thank you, Shashank. I like your scrubs. It's very nice. You're looking in that. Thank you, Dr. Mittal. Thank you, Dr. Krishna. Thank you, Sujoy Koster. Thank you. Wonderful. I hand it back to Dr. Prashant Agarwal for his final take. Thank you so much.
Thank you, sir. Thank you so much for beautifully moderating this session. And I agree with you when you said, all the top 4 top shot endocrinologists from India, they come on the same platform and they discuss about what happened recently concluded American Diabetes Association conference. So definitely it was really very thoughtful and very excellent talk, sir. So now with this, I hand over the session to Ms. Pallavi Paul for the thank you note. Pallavi, over to you.
Thank you so much, Dr. Prashant. And once again, I would like to take this opportunity to express my heartfelt thanks on behalf of Mankind Pharma. I would like to firstly thank all our eminent guests. So starting with Dr. Shashank Joshi, Dr. Amrish Mittal sir, Dr. Sujoy Koster sir, Dr. Krishna Shaji sir, and Dr. Rajiv Koval, who all deliberated on the topic on ADA highlights. And we really enjoyed and we really got a lot of insights from this session and within an hour. And I hope all the audience who has attended the session has the same feeling. And also I would like to thank all those doctors who have participated and attended this session. Once again, I would like to thank all of you for your participation and making this event successful. Thank you so much.
Thank you.
Happy Doctor's Day to everybody.
Same to you, sir.